Hello everyone and welcome to our webinar entitled Case Studies in Management of the Menopausal Patient. Our guest speaker today is Dr. Pamela Smith. My name is Michael Chapman and I'm a medical education specialist at Genova's Asheville branch. I'm going to serve as moderator for today's webinar. We would like to welcome Dr. Pam Smith. Dr. Smith spent her first 20 years of practice as an emergency room physician with the Detroit Medical Center, and the next 16 years as an anti-aging metabolic medicine specialist. She is a diplomat of the board of the American Academy of Anti-Aging Physicians and is internationally known speaker and author on the subject of metabolic, anti-aging, and functional medicine. Dr. Smith is currently the director of the Center for Personalized Medicine and the founder of the Fellowship in Anti-Aging, Regenerative, and Functional Medicine. Dr. Smith is the author of numerous best-selling books, her newest entitled What You Must Know About Thyroid Disease is due out this fall. Before we begin, I'd like to encourage all of our participants to let us know of any technical issue you're experiencing so that we can try to assist you, as well as any clinical questions you have throughout the webinar. Please type these issues or questions into either the chat or questions boxes, making sure to send them to the organizer at any time during the webinar. We will be compiling your questions and answering as many as we can in the final 15 minutes. One of the most common questions we get asked during the webinars is about availability of this presentation and the slide deck. These materials will be available on our website within 1 week of the webinar. If you're interested in having these resources, please click the Clinicians tab on the home page where you'll find access to our webinars. Or you can also log in to find the webinars in your MyGDX account. If you do not have a MyGDX account, please click on the Getting Started link on our home page. And now I'm going to turn the controls over to Dr. Smith. And thank you very much for joining us.
Hello everybody, how are you doing? Glad to have you join us today for case histories in the management of the menopausal woman. So when we look at the idea of what it comes to menopausal and perimenopausal women, first of all, this is from my research. These are suggested dosages for educational purposes only. They are for patients with normal renal and hepatic function, and they're based upon my research, personal and professional experiences after reviewing 20,000 saliva tests over 20 years. They're not intended as a substitute for a personalized approach to each patient, but they are designed to really instead serve as a guideline. So myself and Genova are not responsible for any adverse effects or consequences from these dosages, but they have been used for 20 years and it's a great place to begin. So we want to look as an overview for the health considerations for the menopausal patients, because it's very important to look at common menopausal symptoms and primary menopausal concerns, and really look at some core diagnostics for the management of the menopausal patient. So when we look at some of these symptoms, you can see them here. Wow, there's a lot. And some patients will have very few symptoms, and some patients will have a lot. Memory lapse is one of the most common ones that we get, and let's face it, we look at the idea of memory lapse. If the patient is 20 years old and they lose their keys, they really don't care. They go find their keys. If you look at the idea, instead of a 50-year-old patient, then they go, oh my God, I'm getting Alzheimer's disease. And if the patient's 90, then they probably don't tell us anyway. But very important to realize that many women get symptoms 5 or even 10 years before they go through menopause. So if the patient comes in, normal menopause is 35 to 55 years of age, yes, they could be 30 and have perimenopausal symptoms. The patient will be very frustrated if we don't really understand this. So when we look at the primary medical concerns, when it comes to the perimenopausal and menopausal woman, we do know that hormones are very important for cardiovascular health. In fact, estrogen is cardioprotective. It lends a very favorable profile to the lipid panel, but there is a caveat to that. When we look at estrogen, the studies have shown that it does have to be transdermally applied, which we want to do anyway. But when it comes to cardiovascular health, it is important that we start the patient on estrogen when she first loses it. Now, if a patient comes into the practice, yours or mine, and they're 90 years of age and they don't have a counterindication to hormones, would I put them on hormones? I would. But I do tell them it won't have the same heart and brain protection as it would as if we started them at a younger age when they first lost estrogen. When it comes to bone health, very important to have hormones. Estrogen maintains bone for her. Progesterone does bone building. Testosterone is some bone building, but very importantly, bone strength. DHEA does all of the above, and then it's also important when we look at bone structure to look at cortisol. The patient can take hormones, exercise, avoid alcohol, take nutrients, but if they stay stressed, then it's really difficult for them to maintain bone structure. Because it really is literally a hormonal symphony, a more hormonal symphony. And everything in that symphony, all the instruments have to play in tune. So when we look at core diagnostics for the management of the menopausal woman, then we really want to see what is the baseline and then what happens when we give the patient hormones. So in conjunction with Genova, we actually did a research project where we developed therapeutic ranges. So you will see on the test an actual page that includes therapeutic ranges that is a cover page on their 4 hormone testing, looking at menopause, the Menopause Plus kit, the Menopause Check Plus, and the 1-day hormone check. Genova Diagnostics therapeutic ranges specifically refer to the ranges that were established in a cohort of patients that were on hormone replacement already. Because the therapeutic cohort comprises women who are being treated with hormones due to symptoms or other health problems, the ranges are not normal or abnormal. What they are instead is what happens to have the patient prevent disease and also not have symptoms. A detailed explanation of the therapeutic range cover page can be found on Genova's website at the Endocrine University. So this is what the graphic representation of the therapeutic range looks like. And so you will see here, if you see the first one, it's estradiol, and you will see this particular patient was at 6.6, which is really dead center, kind of where we want people, and so it's in the middle of the therapeutic cohort results. So it's at the 50th percentile. Here you can look at testosterone, and I think you can see very clearly that it's in the first quartile or distribution. And so this patient's testosterone at 43 is in the 10th percentile, so meaning really not into a therapeutic range. We really want it to be dead center of normal in that 50th percentile. So when we look at core therapeutics for the management of the menopausal woman, the first thing is we want to know how much hormone does she really make in a day. Because if she's younger or she's perimenopausal, we want to be able to have it the perfect amount. If she's menopausal, we don't want her to get pregnant. That's not the idea. The idea is to have enough hormone to help maintain function, prevent disease, and of course not have symptoms. And the way to do that is to really go back and look at the 24-hour production rates of steroid, sex hormones in women at different times in their menstrual cycle. And I would like to credit Dr. Sahar Swadan, who is a PharmD who helped me put this together. So let's give an example. Progesterone. As you all know, progesterone, the patient makes more progesterone, or the most, during the mid-luteal phase. and that would be 25 milligrams. Let's look at testosterone. She makes the most during the pre-ovulatory phase, which is 171 micrograms. If we look at estradiol at the bottom, she makes the most at the pre-ovulatory phase at 380 micrograms. If we go back up to DHEA, it stays constant throughout the month, and that's 7 milligrams. So sometimes I see these crazy doses. We know, for example, when the hormone is applied transdermally, actuarial studies have been done, most of it gets absorbed. So when we look at testosterone, and you can see it's micrograms, when we give the hormones, we really don't want to go above 4 milligrams in prescribing, because it's going to be applied transdermally to the skin. It has very good absorption. No reason to go to a dose higher than that. How about the progesterone? Again, the highest dose, 25 milligrams. Applied transdermally, the average doses are between 15 and 40 milligrams. So I never go above 50. It's different if we're giving the progesterone orally, because it has to go through the body and be broken down by the liver, etc. So we would look at more. So how much more would that be? Well, let's say that you're giving her 100 milligrams of progesterone by mouth, PO. Then that would be somewhere in the range of about 25 milligrams transdermally. So you have a general guideline there, switching between oral to transdermal. Very important to start low and go slow. There's two things we want to consider today as a take-home for Monday morning. Start low, go slow, and again, it really is all about balance. We do not ever give estrogen by mouth for hormone replacement. Estrogen by mouth can drive up blood pressure. It can drive up triglycerides. And we know for the studies on women, the women in heart disease different than men in heart disease. Women in heart disease, it's more about high triglycerides and low HDL. Estrogen by mouth can increase estrone, the estrogen we don't want to go up at menopause. Estrogen by mouth can cause gallstones. It can elevate liver enzymes. It can increase sex hormone binding globulin. And sex hormone binding globulin binds testosterone and some of the estrogen as estradiol. When SHBG goes up, there's less testosterone available for the body to use. So I have a whole host of patients I see in my personal practice that are younger women on oral contraceptives, and we have to give them testosterone because it's low due to the oral estrogen inside that oral contraceptive. Estrogen by mouth can interrupt tryptophan metabolization and consequently serotonin metabolization. It will also lower growth hormone, about 50 points. It has prothrombotic effects. We commonly get questions when we look at estrogen. Oh, the patient has factor V Leiden. Oh, the patient's had a DVT. They've had a pulmonary embolus. They can never have estrogen. That's not necessarily true. There are 3 medical trials showing that patients can have estradiol transdermally because it's not prothrombotic. Estrogen by mouth can increase C-reactive protein, a major inflammatory marker. And those studies are showing that when we have C-reactive protein high, that is a major marker for heart disease. And then estrogen by mouth can increase carb cravings. So we never suggest for hormone replacement that estrogen be given by mouth. So methods of dispensing hormones transdermally, we can put it in a syringe or we can put it in a pump. And it's more commonly now the FDA is suggesting a movement from syringe to a pump. And so you will see that being done more now by the compounding pharmacist you work with. When it comes to disease risk, let's spend a few minutes talking about breast cancer risk. In this 2013 study, researchers estimated that over the past decade, between 18,600 to 91,600 postmenopausal women ages 50 to 59 years old who had a hysterectomy may have died prematurely because they did not take estrogen. And this is from the very conservative American Journal of Public Health. Another study, meta-analysis, 27 published studies, 28% reduction in mortality in menopausal women under 60 who used hormone replacement. The patients also had an improved quality of life from the American Journal of Medicine. Other studies have shown that progesterone does not induce estrogen-stimulated breast cell proliferation, but that would be the natural, the bioidentical, the same chemical structure of progesterone, not the synthetic progestin. So there's several trials showing that. And so natural progesterone has been shown to decrease the risk of developing breast cancer. In fact, a study looked at 80,000 postmenopausal women for 8 years using different kinds of hormone replacement. It was found that women who used estrogen in combination with synthetic progestin had a 69% increased risk of developing breast cancer when compared to women who never took hormone replacement. It also showed that women who used progesterone, not progestin, but the natural progesterone, in combination with estrogen, had no increased risk in developing breast cancer compared to women that did not use HRT, and also had a decreased risk in developing breast cancer compared to women that use progestin. So a nice, interesting study. Another study done by the same researchers found a 40% increased risk of developing breast cancer in women who used estrogen with progestins. In women who used estrogen combined with progesterone, there was a trend toward a decreased risk of developing breast cancer. So it really, again, is all about balance. It's all about balance. Before we do the case histories, I really do want to take a second and discuss with everyone, how do you measure hormones? If the patient is not on any hormones at all, can you measure by serum testing? You can. I actually don't myself for 2 reasons. If you measure by serum testing, then later on you want to use saliva testing, and we're going to go through why. But if you do serum testing first and you do saliva later, then you really can't compare them well. It's kind of like comparing an apple to an orange. The other reason that I love to do saliva testing initially is that we have different tests to choose from, so that you can actually do a 28-day test if you want to. You can do a 6-day test. You can do a 1-day test. For menopausal women, we do suggest the 1-day hormone check, which is a 1-day test because the hormones are stable. For younger women or perimenopausal women, we might want to do a larger test. The studies have shown, and I do have references for anyone who would like them, that when the hormones are applied transdermally, then you cannot follow them with serum testing. What happens is, when you put something on the skin, it goes into the red blood cell, and it literally stays for 3 seconds. So even if you're standing there with a syringe, and you measure the person's blood, you draw it right then and there, it's already going to be gone in other tissues. So you're not going to see it when it's applied transdermally in the serum at all. Otherwise, you will end up overdosing the patient. And that's how we get some of these crazy doses. Studies have also shown that when it comes to a 24-hour urine, and I love 24-hour urines, I like to look at estrogen metabolization. I like to look at actually all the metabolites. But I don't dose off of the 24-hour urine. I use it to look at how estrogen is broken down, to fix estrogen metabolization if we need to prevent cancer. I also love looking at some of the more toxic metabolites that can occur and fix those. But I don't dose off of the 24-hour urine. I dose off of the saliva test itself, because that way we're getting what happens with transdermally. We're seeing it on the actual saliva test. We see the bioavailable hormone, how much is available for the body to use itself. So it's the unbound portion, plus what we do with saliva testing is we get the actual hormone itself and not a metabolite. So let's spend the rest of the time looking at case histories. These are actually my own personal patients. So case 1. This patient had a 6-day saliva test. This is very beneficial for the perimenopausal woman, or a 28-day test. For my younger patients, I really do a 28-day test for PMS, for PCOS, for postpartum depression, for infertility, because I want to see over 28 days what their hormones are doing, and that is 11 specimens over 28 days. Otherwise, for the perimenopausal woman, I commonly use the 6-day saliva test because I want to see if she's ovulating. And of course, if she doesn't want to do the 28-day test perimenopausal. I do this test and I start it on day 16 of the cycle. So 16 days after she starts cycling, and the reason for that is because that way we can catch ovulation. If you are going to do a 1-day check, then that should be day 21 of the cycle. So perimenopausal woman. With this perimenopausal woman, here we have the 6-day test. You can see here the therapeutic range, and that's the therapeutic cohort, looking at patients that are already on hormones, so you know where your patient stands in relationship to other patients who we looked at. So this person is perimenopausal. Estradiol is there, and that's right at the 50th percentile, right where it belongs, so she would not need estrogen. The E1 is close to the 50th percentile, and then she does have more E3. This is not a problem for the cycling woman. She does have, though, low testosterone and low progesterone. She's down there in the 10th percentile. So she would benefit from testosterone, which we would give transdermally, and we would give it every day. From the viewpoint of progesterone, studies by Spiroff and others have shown that for the peri and postmenopausal women, we probably should give PO progesterone because it's more protective for the breast than the transdermal. If she has insomnia or a great deal of anxiety, then it's better for this woman to get her progesterone PO anyway, because that way it crosses the blood-brain barrier and hits the GABA receptors and has a very nice calming effect. That is not true for transdermally applied progesterone. So you can see the last one on here is the progesterone to E2 ratio, which is too low because she still has a full complement of estrogen, but not enough testosterone and not enough progesterone. Here you see the actual test results themselves, so you can get the actual numbers. So looking at this, just general guidelines, what we want to do for testosterone replacement, again, it's going to be transdermal, start low, go slow. So somewhere between testosterone 0.75 milligram cream and 1 milligram would be a great place to start. It is important when you have her apply testosterone that she rubs it in for 2 minutes, because it's a cream, but that she rotates sites. If she applies it to the same location all the time, then she will grow hair there. And we commonly use the thigh, just rotate sites. Again, with this patient, I would probably want to do PO progesterone. She's perimenopausal. So we want to give it days 14 through 25, and with this level somewhere like 110 to 125 milligrams of progesterone. Again, that's sustained release, now called E4M. They changed the nomenclature. She's going to need at least that much, days 14 through 25, to balance her estrogen, which is a full complement. So this patient is what we call estrogen dominant. She has lots of estrogen, but not enough progesterone for balance. So here's the actual norms for the estrogen on the 6-day test. Okay, younger women, we're not going to replace estrogen in. It's very important that if she's still cycling, we don't give her estrogen. And I actually have a patient right now that came back to see me yesterday for a revisit. And she saw a practitioner that was not trained in this field, did not measure hormones, and she had migraine headaches, and so she just gave her estrogen to use, even though she was still cycling. Now, if the patient has migraines and they're hormonally related, then basically, if her hormones before, she ended up with that migraine headache just before she cycled, but now, all of a sudden, perimenopausally, she's getting a whole lot of migraines. Maybe before she got 1 a month, and now she's getting 8 or 10 a month. That would be my exception to the rule. I give a baby dose of bias cream, which is estradiol and estriol, at 0.10 milligram cream QD. Okay? And put it on the thigh or buttocks. It has to be an area of fat. Women, no matter what they weigh, tend to have more, quote, fat cells, under quotation, on the thigh or buttocks. Rub in for 2 minutes, again, rotate sites. This would be an exception where if she's perimenopausal and still cycling, I may give her a baby dose of bias cream, and the reason for that is to stabilize the estrogen. She's getting more migraines because the estrogen level is going up and down every day, and it stabilizes it out. But it's a subtherapeutic dose of estrogen, not a full replacement if she is still cycling. When we look at the perimenopausal woman, again, orally, common doses, 25 to 200 milligrams, days 14 through 25. If she tells you that, wow, I feel really fabulous every day that I'm on the progesterone, but I don't feel so great when I'm not on it, then you can give a lower dose, days 4 through 13. So that's something that you may want to consider. Topical administration, again, 10 to 30 milligrams, days 14 through 25. And again, you could do that, a lower dose, days 4 through 13 if you need to. But again, much more now, the world's literature and what everyone is doing is we do give progesterone perimenopausally, much more common now, PO, than transdermal. So here's the norms for progesterone on a 6-day test, again, printed out. So with this particular patient, we gave her a little bit of testosterone, 0.75 milligram cream to 1 milligram cream, and then progesterone. 110 would be a great place to start to 125 PO, extended release if she has a healthy gut, days 14 through 25. And this patient actually did very, very well. Now, case number 2 is patients who are now on hormone replacement. Okay, so this person, as you can see, the estradiol level is low. It's in that 10th quartile. Okay. The estrogen's a little higher than we'd like to see, though. It's way up there in the 80th percent of the quintile or quartile. And in looking at this, we want her E1 estrone to be lower. That's too much, because this is the one that's linked to breast cancer. So the ways to lower this is weight loss if she's overweight, because estrogen is stored in fat cells, or you can do a formal detox of her liver, where you give one of the formal detox powdered drinks for 1 to 3 weeks, and then that will help lower the estrone. The testosterone and progesterone are in the lower percentile again. here's the actual numbers, okay, of the patient. So let's look more at the menopausal woman, and we'll see how she is going to look. Okay, so case number 3, menopausal woman, 1-day saliva test. Love to do this. Here on this 1-day test, the patient's estradiol is low, estrone is low, estriol is higher. When we prescribe the estrogen, we don't give E1 estrone. We do give E2 estradiol and E3 estriol. And the reason that we give estriol is that it balances to the right receptor sites of estrogen. There's estrogen receptor sites alpha and estrogen receptor sites beta. The alpha sites are stimulatory, the beta sites are not. The E1 estrogen binds preferentially to the alpha sites, the one we don't want 3-to-1. The E2 is the 400 functions of estrogen, because for her, estrogen does have 400 functions. So she needs estradiol, but it binds the same to the alpha receptor site and the beta 50-50. The estriol binds preferentially 5-to-1 to the beta site, the one we want bound. And so it's important to give estriol. And so I always, when I write a prescription for estrogen, give estriol, but this particular patient had a lot of her own. So when we prescribe the Biest, E2, E3, it can be any ratio that we want it to be. So this particular patient, you can see that her estriol is way out there in the 80th to 90th quintile, and in looking at that, she doesn't need a lot of estriol. Okay, she would need more estradiol, so you can adjust the ratios accordingly. Testosterone would be needed, progesterone would be needed, and estrogen would be needed as well. So here's the actual numbers. So when we look at this particular patient who actually came in to see me with the following symptoms. Memory is not as sharp. That's the reason that she came in. Looking at it further, in the review of systems, chief complaint is memory is not as sharp. But in the review of systems, she said she had the following: anxiety, irritability, insomnia, mood swings, and depression. She also said she had decreased sexual interest. So it's not surprising what this test showed. This is the 1-day menopause check. Estradiol 2.9. It needs to be 6 to be therapeutic, so she is going to need some estradiol. Start low, go slow. So you can start at something like 0.25 milligrams, 50% E2 and 50% E3. And I usually specify bases when I do this as well. I happen to very much like Versabase, V-E-R-S-A, base, B-A-S-E, because the base it's put in is designed for hormones and it's hypoallergenic, so that people don't get a reaction. She's menopausal, so initially we're going to have her use her hormones every day. Later on, we do want her to take a hormonal holiday, and I'm going to come to that shortly. She does need testosterone. Her level's so low, it's not measurable, so you could certainly start at 1 milligram of testosterone cream. And then she does have low progesterone. She needs to be in the more mid-range. So because she's menopausal and we're going to give the hormones every day, she doesn't need as much progesterone as a younger woman would that was taking it days 14 through 25. So a nice place to start here might be 100 milligrams of progesterone PO. And then the ratio will improve. And that's at the bottom, the progesterone to E2 ratio. So what I like to do initially is commonly the patient's DHEA and cortisol levels are not normal either and not balanced. So I usually start out with the patient that's menopausal, giving them the hormones every day. But about 6 months to 9 months later, they really do need a hormonal holiday. Well, what does that mean? The brain likes to see a different amount of estrogen. So there's two popular ways to do it. The most common way worldwide is to give all her hormones Monday through Saturday and then off on Sunday. Another way of giving her hormones a hormonal holiday is all the hormones days 1 through 25 and then off 4 to 5 days. If she's balanced, she will not bleed because there's no abrupt withdrawal of progesterone. You're stopping all the hormones at the same time. So that would be days 1 through 25 and then off for 4 to 5 days. If the patient is on the thinner side, then she's probably going to have symptoms around the 3rd day. I do. Okay, so I take my hormones Monday through Saturday. I'm off on Sunday because otherwise by about the 3rd day, my brain is not rapid fire anymore. But if she's heavier, certainly you could do it either way. How about DHEA? On this one-day test, cortisol is that first big graph, and below you is DHEA, and below that is the DHEA to cortisol ratio. The way that this is read is that green is the average person, yellow is a standard deviation above or below, and red is 2 standard deviations above or below. So you really want her to be dead center of the green section. And there's different tests you can order from Genova. I like the one-day hormone check personally, and this is the one I use in my practice because I get 4 cortisols. And I always measure cortisol. It's very beneficial because it's part of the hormonal symphony. And I like to get 4 cortisols because I get at 8 in the morning, 12 noon, about 4 p.m., and about 11 p.m. at nighttime. So it will literally tell me what is going on with the patient. For example, you can see in this particular patient, the cortisol's high in the morning. So I know she did not get restorative sleep. That's very important because if she doesn't sleep well, cortisol goes up and insulin goes up too. You can see she's almost dead center of green by noon, and then the afternoon and evening specimens are high. So 3 of her 4 are on the high side. So what do? The following. Number 1, stress reduction techniques, prayer, meditation, tai chi, yoga, qigong, exercise, massage, breathing techniques, something. Okay? If she's a really busy person, she can, when she gets stressed, 2 or 3 times a day, sit at her desk and just do 10 deep breaths. Hold it in, hold it out. It's great, very therapeutic. Also multivitamin. The adrenal glands do require a lot of nutrients that are in a multivitamin to work well. And then adaptogenic herbs, ashwagandha, ginseng, rhodiola. Now, if the adaptogenic herbs have ginseng in it, then it may keep her awake. They're usually given BID, so I have the patient take it in the morning and around 5 p.m. If she's stressed and wired, then I also give calming herbs like chamomile, lemon balm, etc. I do advise the patient that it will take 1 to 2 years to normalize cortisol. So part of this reason the patient's memory was not as sharp was low estrogen, but it's also because cortisol is not normal. But it will take 1 to 2 years to fix this. DHEA has to balance with cortisol. Again, it should be dead center of green. Women need a lot less DHEA than men do. And so start low, go slow. Something like 3.5 milligrams. And then usually most people give it PO, as do I. So you can start at 3.5 milligrams sustained release, but remember sustained release is predicated on a healthy gut. If you just give her DHEA and you don't give her adaptogenic herbs and multivitamin, etc., to help fix cortisol, you just give her DHEA, then you'll be surprised. The next time that you measure the DHEA, it's actually going to be lower. So you do have to support the adrenal glands with those adaptogenic herbs. So when I first see a patient, I do their interview, physical, etc. I bring them back when their saliva test is back to go over what the results are and what we're going to prescribe because it's very personalized care, and then I retest everybody in 90 days and then every 6 months. I used to, in menopausal women, because their hormones stay the same all the time, just do them every year. That's not good enough. They actually have more changes than you would think. So do the first one, go over the results with the patient, repeat it in 90 days, and then every 6 months thereafter. DHEA replacement, again, should be dead center of the green. In really younger women, you may not need to replace DHEA. You may need to just fix the stress hormone, cortisol, and then DHEA may pick up. But in the menopausal woman, it's going to be low due to age. We talked about this clinical pearl, and then here again is the cortisol. There's all the things you need to do. If the cortisol is high in the evening and it stays there, what you can also do is give phosphatidylserine. I love phosphatidylserine. It increases acetylcholine, the main neurotransmitter of memory, and it's also great for cortisol that's high at night. The dose for someone who's an adult with normal renal and hepatic function is 300 milligrams. It doesn't matter what time of day they take it, it will help lower the evening cortisol. Now, we also use this dose of phosphatidylserine for ADD, ADHD in adults. You can use it in kids, but a lower dose. We use it in college students to get the competitive edge. Great studies on phosphatidylserine, wonderful studies to prevent memory loss, treat memory loss. It mixes with Namenda and Aricept and all those medications we use for cognitive decline. We use it for closed head injuries and post-stroke, up to 5 years. Whether the stroke was hemorrhagic or not, it does not matter. But we do want to do something for cortisol levels that are too high. If cortisol levels are too low, which is what will occur when the patient has been having abnormal cortisol for a long time, at first they elevate, later they become too low. If they're too low, we do the same thing, but if we've gone on now for 6 or 9 months and the adaptogenic herbs are not working, we take them off of the adaptogenic herbs and instead give them adrenal extracts. They're purified, so you don't have to worry, but that's only for cortisol that's too low. Adaptogenic herbs mean it's adaptogenic. It helps if the cortisol is high or too low. Extracts only if it is too low. Melatonin, I personally don't prescribe melatonin in my practice unless I measure. Because if you give the patient melatonin and they don't need it, serotonin goes down. And again, women are much more sensitive than men. This is a melatonin test. It's done in the morning around 4 p.m. and 3 a.m. with the lights off. And again, it should be dead center of green. The yellow, 1 standard deviation above or below. The red, 2 standard deviations. This 3 a.m. specimen you can see here is too low. It should be dead center of that green. So there's 2 reasons why this would happen. A, the patient really needs melatonin. Or B, what happened with this particular patient is they put the lights on when they did the test. So I have them put the saliva testing tube right at bedside. Do not turn on the lights. And all of these are a frozen specimen. So what I have the patients do is they leave their little container that holds the test tubes in the freezer. When they finish each tube, then they put it right in the freezer and then they send it off. So very important to have the right amount of melatonin as well. So in conclusion, in looking at this, and then we'll take questions. Number 1, I can tell you from being a menopausal woman myself, it is the best time in her life. Encourage her that. When you replace her hormones and they're balanced, she will feel fabulous every single day. So important. When we look at that perimenopausal woman, we want to help guide her through menopause so she doesn't have a lot of symptoms and we prevent disease. So there really is the perfect dose for everybody. That's why I love this kind of approach, because it's customized and personalized. We don't have to look at just the cause of the problem. We can look at we look at the cause and not just treat symptoms. It is important, though, to measure. I don't think anybody out there would give someone thyroid medicine without measuring thyroid. Same thing with estrogen, progesterone, testosterone, DHEA, cortisol, melatonin. We actually want to measure and have the science guide us with that patient. And you will know when the sweet spot is. It will be that patient that comes in and says, "Hi, I just want to do saliva testing. I don't want to do anything else. Give me my kit. I'm out of here." And when the results come back, all the hormones are dead center. That patient was asymptomatic. And you'll also see that the ratios between those hormones are also dead center of normal. So, Michael, let's open it up to questions.
Sounds great. Thank you, Dr. Smith. That was a terrific presentation, and we've already received a lot of good feedback. I just want to remind everyone that the PowerPoint will be available on our website in PDF format. We did receive quite a few clinical questions. So let's start with, there's one question. If you have a patient that comes in and is already on oral bioidentical hormones, do you take them off prior to testing? And if so, how long do you take them off for?
Okay, that's an excellent question. If we're looking at oral estrogen and testosterone, that's going to be problematic, even if it is natural, okay? So honestly, I don't take them off. What I do is I know what the dose is, and then I get my saliva test, and I basically look at the idea of what we can do to go back and have better balance. And so you can see that the ratio of something where you really want to change it back and forth, the ratios are known. So why don't I do this? You know what, Michael? I'm going to send out a slide to you to put on the website of ratios so that you know how to change what percentage of oral translates into what percentage of dermal for each hormone. How does that sound?
Yeah, that sounds great.
And then everybody will have it. You can put it on the website, and then it will be easy to do because you'll actually have those ratios. Okay?
Sounds good. Had another question around concerns about parabens in the particular creams that are being used.
Well, it depends on what base that you're using. You do have to have things in it that are keeping it okay, but with the bases, it depends on the base that you use. You can find non-paraben based bases, and so I would definitely look for those.
Great. And do you have a preference around progesterone? Do you normally use micronized progesterone, or do you generally have it compounded?
I really do have it compounded because you can get the perfect amount. I mean, you can look at, there are pharmaceutical companies that make bioidentical progesterone, like Prometrium, but it only comes in 2 doses, 1 and 200 milligrams. And so commonly that's not the perfect dose. For example, myself, my perfect dose of progesterone is 110. Could I take Prometrium at 100? I could, but it's not the perfect. So I almost always have a compounded. That way I can put it in whatever base that I want, and it does matter the quality of the hormone as well. So I do personally have all of mine compounded.
All right, and we had another question. If you have a patient who's not improving, how often or how quickly do you retest and then potentially change the dose for that patient?
Great questions. There is a little caveat. So let's take estrogen, for example. What happens if the patient calls up and they said, "Hey, estrogen, my patient had hot flashes." They called up and they said, "For the first 60 days, I felt fabulous. The hot flashes are gone, and now they're back." What happened is you actually overdose the patient. So don't give more, because what happens is if you overdose, it saturates the receptor sites. And when it saturates the receptor sites, it doesn't hold on to more hormone very well, and the patient will get hot flashes. So instead of giving more, actually back down on the dose, and the patient will do better. It does take 90 days when you give estrogen for it to go back and balance with the other hormones.
All right, great. And another question around if you have a patient that you're managing with bioidentical hormones and they start developing weight gain, how do you sort of mitigate the weight gain symptom, but then if you lower the dose, then they start becoming symptomatic with some of their other symptoms?
Another great question. The most common reason people get weight gain when you gave them hormones is that the balance wasn't right between of the hormones. In other words, the ratios weren't correct. So this week, I saw a patient who came new to me, and we did a Genova saliva testing kit. She had seen another provider, and she had gained 40 pounds in 2 months. She was absolutely hysterical. She had to go out and buy new clothes, and she just wanted to give up on hormones altogether. When we got her saliva test back, we were talking about 6 for estradiol as being the 50th quintile. She was more than 100 quintile. Her actual number was at 52,422. So she had so much estrogen on board that's why she gained the weight. The same thing will happen if you give too much progesterone. The patient will gain weight also if you don't replace testosterone. So that patient that gains weight, there's an imbalance between the different hormones themselves.
And I think another maybe clarifying question for postmenopausal women, are your protocols, do you aim for dosing that will bring a patient to normals for a menopausal patient or normals for young women?
That's another great question. Generally, what we're trying to do is turn back the clock about 15 years. Okay, so when we look at the menopausal perfect therapeutic range, we really turn it back to about age 35 or so. Also, it does, as patients age, they usually, by and large, need less hormone to produce the same desired results in how they feel and on testing.
And then, do you consider a rapidly dissolved tablet for progesterone, do you consider that to be similar to the other oral supplementations?
Not if it's compounded. Again, it will depend on the form of the hormone that you're using. I usually like to use sustained release if they have a healthy gut, because then, for example, for progesterone, it's going to work for 24 hours. And so she'll have a nice calming effect the whole time. But the gut has to be healthy. If the patient, has reflux, diarrhea, constipation, etc., then that sustained release capsule is just going to sit in the gut and not do what it's supposed to do. So while I'm fixing their gut, then I usually do give immediate release, and then I can change it to sustained release. And again, I don't guess on the gut. I do the GI effects test, and it really does guide me on where I need to be with the gut as well. Got to fix the gut. It's just as important as all the rest of this.
Had another interesting question around what's the youngest patient that you've treated for perimenopause?
The youngest patient I've treated is 32. And she did go through full-blown menopause at 35. People usually go through menopause about the same time their mom did. Her mom went through menopause at 36. So for me, 32.
And then I think just one last question here. What sort of resources would you suggest to stay current on prescribing hormone therapy?
Well, there's a lot of different resources. My book, What You Must Know About Women's Hormones, was written for patients and providers. There's almost 1,000 references in the back from conservative medical journals. So What You Must Know About Women's Hormones is a great resource. Anybody who's on the webinar that would like to receive it wholesale, just let us know and we will make that happen. The other thing is really training. From the viewpoint of training, Module 1 from the Metabolic Medicine Institute and A4M, Module 1 is on hormones only. And it really does give you a good way of learning. With Module 1, you can take it in person or you can take it online. Also, if you want to get really, really good prescribing techniques, then take Module 1, and then there's a workshop called Advanced Protocol Prescribing for Hormones. That workshop will be run June 24th through 25th in San Diego. So it's a 2-day workshop, very inexpensive. You do have to have taken Module 1 as the core to attend the workshop, or it wouldn't make any sense. And then it will be archived, so we will have it available as a tape in July. So we do recommend training. because it does change over time. I mean, 5 years ago we would have said, progesterone transdermally is fine for any age group. So things do change over time.
Great, thank you very much. In the interest of time, we'll end our question and answer period there. For additional information and educational materials, we'd like to encourage you to visit our website, www.gdx.net. On this site, you'll find sample reports, kit instructions, and other information for all of our profiles. I wanted to mention that we recently updated our website, so it might look a little bit different from what you may be used to. Also wanted to mention that we're having the second installment of our Learn GDX seminar series in Fort Lauderdale, Florida this upcoming June. This will be a one-day event focusing on management of the menopausal patients on Saturday, June 11th. Speakers include Dr. Pamela Smith and Dr. Andrea Gurman. For more information, please visit our website.
And that's a fabulous one to look at. It really is. On June 11th, there's going to be some whole new information there that we haven't presented before, so that would be a wonderful one to have people attend.
Great. And after taking advantage of the materials found on our website, feel free to contact client services with your questions. You'll see a number on the slide for US and UK customer service. Additionally, please call client services if you need assistance in setting up a MyGDX account. We also offer complimentary appointments with our medical education specialists to answer questions related to our testing, including choosing the right tests and reviewing patient test results. And finally, we'd like to encourage you to look for our upcoming webinars on www.gdx.net. Next month, we'll have Dr. Alan Antoine, who will be presenting on the steroidogenic pathway, understanding what influences each step. And thanks again, Dr. Smith, for a superb presentation.
Oh, thank you so much. Thank you, everybody, for attending.
Have a great day.